Now, this is a section of the skull with the scalp, and you can see the brain, gyri and sulci. This is the bone. Now, the layers of the scalp, the skin, the connective tissue, aponeurosis, loose areolar tissue, periosteum, bone. Soft tissues covering the clavidia of the skull extends up to the supraorbital margin in front and external occipital protuberance and superior nuchal line behind. Zygomatic arch on each side. You go to the dissection hall or you have a skull, you please know the boundaries. And the soft tissue covering the clavidia of the skull extends up to the supraorbital margin in the front. The supraorbital margin in the front. External occipital protuberance and superior nuchal line behind, zygomatic arch on each side. The zygomatic arch, you can feel layers of the scalp, the skin, subcutaneous tissue, aponeurosis, Galea, Aponeurotica, loose subaponeurotic tissue, pericranium, the periosteum. Yeah. You can, if you can dissect, you can take by layers. The layers you can separate and dissect out. Now, subcutaneous tissue, closed network of fibro-fatty tissue, contains blood vessels and nerves of the scalp. The walls of the vessels are firmly adherent to the fibrous tissue. Minor scalp injury results in profuse bleeding. Yesterday I told you that a minor injury, a cut, it will bleed. And now Galea, Aponeurotica, epicranial aponeurosis, the frontal belly of occipital frontalis, the occipital belly of the occipital bone, orbicularis oculi. Now the trapezius muscle. Now see, situated between the occipital bellies and frontal bellies is occipitofrontalis muscle. Attached behind to external occipital protuberance and highest nuchal line. In front of blends with the subcutaneous tissue at the root of the nose. On each side attached to the zygomatic arch. Loose subaponeurotic tissue. Consider loose areolar tissue contains of emissary veins devoid of valves. Emissary veins. What are emissary veins? It has no valves. Okay. Now, this is the dangerous area of the scalp. Collection of blood in this space produces generalized swelling, black eye. So you hit a person on the head and next morning you see black eye swollen. The collection of blood in space produces generalized swelling, black eye, head injury with pericranial tear, safety valve hematoma, traumatic vault fracture with meningeal tear, cephalohydrosis. Pericranium, the outer periosteum of the skull, as the sutural lines continues with endocranium. Collection of fluid produces localized swelling, assume the shape of the related bones. Now, if you hit in the parietal bone, then the swelling will be pertaining to that parietal bone. Now, nerves and arteries of the scalp. This is the supratrochlear nerve, supraorbital nerve, zygomaticotemporal nerve, temporal branch of facial nerve motor, auriculotemporal nerve, great auricular nerve, posterior branch of facial nerve motor, lesser occipital nerve, greater occipital nerve, Third, occipital nerve. The occipital artery, the posterior auricular artery, the superior temporal artery, supraorbital artery, and supratrochlear artery. You can get a short note. And this picture is very, it speaks. It speaks. The arterial and nerve supply of the scalp. The nerve supply of the scalp, front of the auricle, supratrochlear, supraorbital, zygomatic temporal, temporal branch of the facial, auriculotemporal nerve. Behind the auricle, posterior branch of great auricular nerve, C2, C3, cervical 2 and cervical 3, posterior auricular branch of facial, lesser occipital nerve, C2, greater occipital nerve, C2, and third occipital nerve, C3. Arterial supply of the scalp, front of the auricle, supratrochlear artery, supraorbital artery, superficial temporal artery, posterior auricular artery, and occipital artery. Venous drainage of the scalp, you can see the vein here. This is the external jugular, internal jugular, this is the facial vein, the posterior auricular vein, maxillary vein, occipital vein, transverse facial vein here, cut, superficial temporal vein, parietal tributary of superficial temporal vein, temporal fascia and muscle. Here, this is the temporal muscle and fascia. Here, this frontal tributary of superficial temporal vein. This. Now, venous drainage, supratrochlear and supraorbital is the angular vein. Angular vein continues as facial vein, superficial temporal and maxillary, a retromandibular vein, anterior division of retromandibular vein and facial vein, common facial vein. Common facial vein drains into the internal jugular vein, posterior auricular vein and posterior division of retromandibular vein is external jugular vein. Occipital vein terminates in suboccipital plexus. Venous drainage. Venous drainage of the scalp is important and how it is forming. And it can come as a short note. The occipital nodes, submandibular node, deep cervical node, superficial cervical node. Now, especially children, they get some impetigo in the scalp or some boil or abscess. The mother complains of the gland swelling. Then you or had a episode of impetigo or your abscess, but that is subsided. Inflammation after giving some medicine. So, but she comes and complains to you that the glands are swelling here. Then you have to assure her, you ask her that did the child have any infection, abscess or impetigo? Then you assure her that okay, it's all right, it happens. One thing. Second thing, these neck glands are common for tuberculosis, cervical lymphadenopathy, tuberculosis. So you have to also investigate, does the child have if there is no impetigo, no abscess or any cut injury, then you think of tuberculosis. Now, lymph vessels in the anterior part of the scalp and forehead drain into the submandibular lymph nodes. Submandibular lymph nodes here, deep cervical nodes. Now, you see the lymph nodes and the venous drainage, the arterial supply. Beautiful picture. Drainage from the lateral part of the scalp above the ear. is into the superficial parotid, preauricular nodes here. This is the parotid. This is the parotid gland. This retroauricular mastoid, deep cervical, superficial cervical, external jugular vein, subclavian vein. Now, parotid, retroauricular mastoid here. The drainage from the lateral part of the scalp above the ear is into superficial parotid, preauricular node. Lymph vessels in the part of the scalp above the and behind the ear drain into the mastoid. Vessels in the back of the scalp drain into the occipital nodes. All these groups of lymph nodes are drained into the deep cervical nodes. Group of lymph nodes. Applied aspect. Surgical plane, loose connective tissue. Tissue expanders are inserted here. Loose connective tissue is also the dangerous area of the scalp. Reason blood and pus due to injury are accumulated here can spread into the dural venous sinuses. Meningitis and then may lead to thrombosis, black eye and cephalohematoma are related to scalp. Now, injury on the scalp can lead to this, and you have to take proper care with antibiotic, analgesics and all. Along with it, before that, you have to take, prescribe this and then send for a plain X-ray, radiological investigation. Second, CT scan brain with dye or without dye. Because these two, because skull itself is very hard to crack. The bole na a hard nut to crack. তাকে কিছুতেই বোঝানো যাচ্ছে না. You cannot make him understand or you cannot tell him a hard nut to crack. He sits with his own argument. Okay. Now, one thing I tell you, I met Professor ITN Jackson. What adjective to use, I don't know. Craniofacial maxillary surgeon. He is based in New York. But he's in America for 15 days or 10 days. Then he goes to Europe, he goes to Australia, goes to China, every continent. Because he has such acumen, such skill, really you cannot believe. One lady, he held a live workshop in Amri, your Gold Park, Amri Gold Park. I happened to attend that workshop. I had some exchange of papers and all, I gave it to him. A patient was operated twice in Indian patient, in Apollo, in other hospitals in South. She met with a RTA, road traffic accident, and see her, she was badly mutilated, her face, the things have changed, total things have been changed, distorted. So, the operation Professor Jackson did is, now the lady's bridge of the nose was like this. It went inside. Okay. The zygomatic bone bit fractured and went like this. What he did, he made an incision here and he took the whole scalp and brought it up to this plane. Like you wear gloves, you take it out. You pulled it up to this place. Then this skull bone is exposed. He took a marker pen and he drew up like this. 2 places, 3 places. He took a saw of the pen, like the pen size. Now, if you see what he did, skin is put up in front, and then he took the saw and went up to the bone. The bone, the scalp is removed, actually it's brought it up to here, it's not removed. When the bone is exposed, he took the saw and just cutting. Again, again, and Now see, what I want to explain is that the skill, the bone he could took, but the meninges and thing, anything, duromata, pyomata, the brain tissue would be, माने घिलू घेटे जाए ना, you do khichdi. Now with this, he took a small chisel and with tuck, he lifted up the plate, bone. And then again, what he did, the zygomatic bone he wanted to replace. Now this is a big plate he took. He took 3 screws, he replaced the zygomatic, this fracture, lifted up, then he fixed it up with 2 screws. Now this was crushed like this, actually this was set. Then he took a piece of bone, it was nasal bone, and over here, he picked up the fractured bone and took a piece of bone from this plate. He took that like this and asked the OT sister, "Sister, do you have a small screw?" She got nervous because she didn't have such a small screw. Probably in Amri's OT in Gold Park, this was this type of operation being performed first time. So, okay, don't worry. Do you have steel wire? Yes. Then he took the steel wire. He made a small hole with a drill. Small drill. And this was placed here. And he fixed it up with a wire. Steel wire. Now, see, what I want to say is that the anatomy, the surgical consequences, and also the conditions which might uh, uh, create a complication, it was not so. Then what he did, he pulled the thing like a cap. You have these caps, who's wearing a helmet. They wear or small like a small. He put it in the like a pagri. He pulled the thing, brought it up to the back, and then sutures. But he put that and he waved because he had to take a flight to Chennai. And the assistant did the rest. Now, some of you, I pray and expect that you might become a neurosurgeon or craniofacial maxillary surgeon. Nothing is impossible. Nothing is impossible. Think that whenever you are handling the dead bodies, handle as if it's a living body. Because now we have 2 or 4 brains. Now, if you just mutilate, don't mutilate, please. There are specimens in different museums in the world, especially Hunter's Museum in London. John Hunter, you have a portrait, a picture of John Hunter at the backside. I have to bring it because in a hurry, it was put in the backside. John Hunter was a school dropout, but he wrote 13 volumes of books, and till date, John Hunter's caliber, there is no surgeon till date is produced. Many things can happen. You have to just study, integrate your work, what you are doing, and group study. 2 can be a group, 4 can be a group, 6 can be a group. Your roommate can be your group. Please, without this, you cannot.